aims to balance cure and quality of life outcomes in long-term childhood cancer survivors. The objectives of today's talk are to increase your ability to discuss long-term health consequences of treatment for cancer during childhood and adolescence, to recognize how late effects have contributed to the evolution of pediatric cancer therapy, and to identify resources to facilitate risk-based survivorship care. Survival rates for childhood cancer continue to rise, such that in the United States, more than 80% of children diagnosed with cancer will achieve 5-year survival. Survival estimates are comparable globally across other high-income countries, and efforts are ongoing to advance survival in low and middle-income countries. Contributors to this progress include participation in collaborative clinical trials, findings from cancer pathobiology that have been translated into novel therapeutics, advances in diagnostic imaging, radiation technology, and supportive care, and recognition of late effects. Childhood cancer survivors are at increased risk for a spectrum of physical and psychosocial morbidities that may affect growth and development, organ function, prospects for future fertility and reproduction, risk of subsequent carcinogenesis, and many aspects of psychosocial functioning. Health concerns are typically related to a specific cancer treatment modality, but may be related to the childhood cancer experience and its subsequent impact on survivor and family functioning. Importantly, health concerns are reported by virtually all long-term survivors. While overall survival is improved, survivors remain at increased risk for mortality compared to the general population, as shown in this figure, illustrating survival function estimates in relation to time from diagnosis for individuals in the United States population, represented by the yellow curve, and participants in the retrospective multi-institutional childhood cancer survivor study, represented by the blue curve. This increase in late mortality is largely driven by chronic health conditions. By 30 years from cancer diagnosis, deaths from chronic health conditions, represented by the yellow curve, exceed that of mortality from cancer recurrence and progression as a leading cause of death in survivors. A number of pediatric cancer cohorts have evaluated the prevalence of chronic health conditions in long-term childhood cancer survivors 20 or more years from diagnosis. As noted in selected studies summarized in this slide, approximately 2/3 of survivors will experience at least one self-reported condition, while 1/3 have a severe or life-threatening condition. These numbers are higher for those for whom conditions are directly assessed compared to self-report, as depicted in yellow for the prospectively assessed St. Jude Lifetime Cohort Study. This slide illustrates different methods of evaluating risks for chronic health conditions in childhood cancer survivors. The figure on the left shows the cumulative incidence of having at least one grade 1 through 5 cardiovascular conditions in childhood Hodgkin lymphoma survivors in red, compared to community controls in blue. You'll note that by age 50, controls appear to catch up with the level of morbidity experienced by survivors. However, using the cumulative burden metric, which accounts for multiple and recurrent health events illustrated by the figure on the right, these two curves no longer converge. Survivors continue to experience a greater number. The same pattern is apparent if one evaluates the total number of chronic health conditions as noted in the table compared to controls. Here we see that on average, survivors experience approximately 8 grade 1 through 5 chronic health conditions at age 30 years, compared to 2 in controls. Similarly, survivors experience approximately 5 severe or life-threatening conditions by age 50 years, compared to 2 in controls. This figure shows the distribution of these conditions across various health systems in survivors of ages 30, 40, and 50 years old by disease category. On the left, you see the distribution of conditions among community controls. What we observe is that survivors experience a number of conditions that increase over time, noted here by looking at cardiovascular conditions in Hodgkin lymphoma survivors, and many that remain highly prevalent but static over time, in this case, neurologic conditions in CNS tumor survivors. As illustrated in this slide, extensive research has described a variety of patient-related, provider-related, cancer-related, and healthcare system-related factors that contribute to cancer treatment-associated morbidity. Early observations associated radiation with musculoskeletal growth defects, while later cardiac events and subsequent malignant neoplasms were observed and then systematically studied to confirm risk. Recognition of these associations between cancer treatment and late effects have been a key stimulus for change in childhood cancer therapy. Hodgkin lymphoma is an excellent example of this. The availability of multiple effective regimens informed the development of clinical trials summarized in this slide that manipulated cumulative doses of specific agents with the goal of limiting late toxicity based on risk presentation without compromising cure rates. Note the doxorubicin dose across these treatment regimens, which varies between 150 and 340 milligrams per meter squared. Numerous studies have demonstrated clear associations between cumulative anthracycline dose and subsequent risk for heart failure. A dose threshold of 250 milligrams per meter squared is considered the point at which the risk begins to increase most significantly. However, depending on host factors and additional exposures such as radiation, even lower doses impart risk. Similarly, studies have aimed to reduce or eliminate radiation for those individuals who respond well to early phases of treatment with the goal to reduce the well-described risk for breast cancer in females exposed to chest radiation. This risk begins to rise around age 25, or typically 8 years after radiation exposure, can parallel that of women with BRCA mutations in the general population, and is influenced by ovarian hormones and thus inversely by concurrent ovarian radiation. These findings have led not only to elimination of radiation for patients with favorable responses to chemotherapy, but also modification of radiation fields over time. In the figure above, you can see the gradual reduction in tissues exposed to radiation depicted in light green through the evolution from the mantle field to involved field to involved node. With this reduction, the exposures to the surrounding tissue, as noted in this figure, such as breast, heart, lung, and thyroid, have dramatically decreased and therefore also have these organ toxicities. These examples highlight how knowledge gained from late effects research has improved and have been important in the development of risk-stratified therapy that titrates therapy type and intensity for modalities such as anthracycline and alkylating agent chemotherapy and radiation. Late effects research has also informed risk-based health surveillance that link therapeutic exposures with specific chronic late effects and matches the intensity of screening with the magnitude of risk. This surveillance can facilitate early detection of late effects and provides opportunities for prevention and remediation that can improve or preserve health and long-term survivors. Data from nearly 35,000 participants in the childhood cancer survivor study support the success of risk-adapted treatment strategies that lower treatment exposures for favorable disease presentations, as demonstrated in this figure showing reductions in overall mortalities over the 3 decades during which study participants were treated. A similar pattern of reduction in morbidity over the treatment eras was also observed in the CCSS, as depicted by decreasing cumulative incidence of grade 3 through 5 chronic health conditions on this slide. Therapy changes have produced a shift with reduced risk of life-threatening late effects, particularly among survivors with more biologically favorable cancers, to that of life-altering late effects. But even with this progress, we still have much to do, as childhood cancer survivors remain a medically complex population with diverse healthcare needs who are at risk for a number of adverse psychosocial and medical outcomes related to the complex interaction between these risks. Therefore, anticipating an individual survivor's potential risks for late effects requires consideration of patient, cancer treatment, and healthcare system factors that contribute to the magnitude of risk and affect that survivor's access to survivor-focused care that includes surveillance and interventions for late effects and measures to mitigate the risk. Survivor-focused care can be facilitated by the development of a survivorship care plan that considers risk contributed by the cancer and its treatment, comorbid health conditions, the family histories, and health behaviors that may modify the risk. And importantly, the care plan should outline risk-based screening recommendations. Several cooperative and institutional groups have developed exposure-based health surveillance recommendations. The Children's Oncology Group Survivorship Guidelines, available at survivorshipguidelines.org, provides a comprehensive resource for this purpose. Recommendations in the COG guidelines are categorized by any cancer experience, specific chemotherapeutic agents, radiation to target organs, history of hematopoietic cell transplant, history of specific surgical procedures, and other interventions in pediatric cancers. In addition, the COG guidelines includes recommendations for high risk and general risk adult onset cancer screening. The COG guidelines are updated every 5 years following review and grading of evidence from comprehensive literature searches on exposure-related late effects. The COG guidelines are all in multiple languages and can be individually downloaded and printed free of charge. Surveillance recommendations for the highly prevalent late effects have been harmonized through the efforts of multidisciplinary international investigators working in the international guideline harmonization groups. These recommendations and a summary of ongoing IGHG activities are available at ighg.org. While these resources may be leveraged to develop a survivorship care plan, oncology providers should be mindful of the action required to implement the care recommended, whether the information is summarized on a printed or online document. The survivorship care plan is a process, not a piece of paper, and calls for the oncology team to consider the specific cancer history and treatment, to specify a primary cancer surveillance plan, to outline cancer and cancer treatment-related health risks, to detail subsequent cancer and late effect screening, to address lifestyle factors that impact cancer-related risks, to include screening for and management of comorbid health condition, to define the roles of involved providers, and to identify resources to address medical and psychosocial needs. Long-term follow-up after completion of therapy varies by regional and national healthcare systems and resources. Some survivors have access to specialized long-term follow-up clinics or oncology clinicians to share care coordination with primary and subspecialty care providers. But generally, this is a small proportion. Most long-term survivors will age out of pediatric programs and receive care by community providers who are unfamiliar with late effects and the special health needs of childhood cancer survivors. Because of this, survivorship care remains an important focus of study, especially care of aging adults treated for cancer during childhood. The models of survivorship care remain highly individualized and variable across health systems. The level of care that is provided and model of care is dependent upon the risk of recurrence and late effects, the types of services rendered, and the timing of said services, as noted in this slide. In summary, I hope you have appreciated through this presentation that childhood cancer survivors are at increased risk for chronic health conditions compared to the general population. Cancer treatment has been modified over time to reduce treatment-related exposures that increase risk for adverse health outcomes. Risk-based guidelines provide recommendations regarding care delivery for this medically complex population. A variety of care delivery models exist and should be adapted to local resource availability. Thank you for your attention.